The first clinical sleep centers in the United States started to be about 1975. So it's one of the most youngest fields of medicine. At the same time, in terms of knowledge, it has exploded tremendously. But unfortunately, I would kind of aim that criticism at myself and my colleagues. In terms of responding to the public need, we haven't been able to do it. Still, probably somewhere about 90% or at least 80% of patients with sleep apnea only are not diagnosed. And from those that are diagnosed, only half, even less, are treated. And given the toll it takes on quality of life, on learning, on accident, and especially huge impact on cardiovascular diseases, strokes, heart attacks, heart failure, it is something that we have to think of it differently and systemically in order to answer to that public responsibility and public call. I must add to that that the healthcare economic burden of sleep apnea is considered to be somewhere between $65 to $160 billion a year, depending on what services you put into that, plus a lot of lives lost. And now more evidence is coming that shows that it plays a role in development of chronic kidney disease, in development of fatty liver disease, and maybe even it makes solid cancers more to grow more aggressively. So there are a lot of factors into that. There are a lot of negative impacts of that the profession has to try to find solutions for them. Of course, one end of it is to increase public education, so they suspect it. And let's say if you drive and you doze off, you don't write it off as something that's normal. That said, you have to utilize and employ new technology, such as electronic medical record and other healthcare professionals that team up with physicians in order to have a valid and applicable screening method. You don't wait for disease to come up and shout at you, because by then usually you cannot control all negative impacts downstream. Like you don't wait for someone to have stroke and then say, oh, you have high blood pressure. You monitor patients. So that's true throughout. That's true in COPD, as we discussed a minute ago. And that certainly is true in a condition like sleep apnea, given its huge impact. I must say that is fairly good in terms of accuracy. It can miss, like every other test has some margin of error. And I don't think it's that uncomfortable, but of course it's inconvenient. Today there's also home sleep testing, which doesn't have exactly the accuracy of lab testing, but in the right setting may be a substitute for that. So probably right now about 25 to 30% of tests can be done outside. As the outside testing becomes more sophisticated, this number may go up. So that's another available modality. Still, CPAP and its other variations, BiPAP, etc., remain the gold standard, as you said, although there are a lot of improvements in that. And servos, or as opposed to autopaps, also have offered in certain patient improvement. But there are two other factors to consider. One is not to give up on these patients, because when people cannot use it, it's not an all or nothing phenomenon. You have to have a checklist and ask, is your nose dry? Do you have difficulty with breathing out? And kind of find out what's the problem and try to treat it and be encouraging to the patient, partner with them and stay with them. In addition to that, things such as treatment of nasal occlusions is helpful, weight loss is greatly helpful, use of mandibular devices have improved a lot, and in a lot of conditions, at least in mild to moderate, and maybe in more severe conditions, either can be quite effective or can be effective in conjunction with CPAP. In addition to that, there are newer modalities coming. One of them is hypoglossal nerve stimulation, which is something like a pacemaker, basically, that increases the tone of muscles of the pharyngeal ring, and therefore treats patients with sleep apnea, and is quite effective in the right subpopulation of patients. The theory is this, that you have a sensor and diaphragm, and as soon as the diaphragm starts to contract, which is the beginning of a breath, it senses that and sends a signal to the muscles that basically keep the throat open, and those muscles contract and therefore allow the air to come in, because they prevent the initial collapse of the airway. Sleep disorders are, as a whole, the first day that the initial human clans had fire and could sit around the fire and tell us stories, obviously sleep disorders started, but without that you couldn't have civilization either. That said, obviously weight gain is part of it, living longer is part of it. So these are all factors, and basically it seems that one trade-off that we have in civilization and growth of human is the ability to talk also makes your airways susceptible to collapse. So that's a trade-off that we made. But thanks God we can talk. The economic impact is huge. Only for sleep apnea, you have that. If you consider all the sleep disorders together and you look at how different types of insomnia, poor sleep, mild sleep apnea, and so on, make people fatigued, unable to work well. Therefore, there is a huge reduction in efficiency of the workforce, in accuracy of the workforce, in professions that requires accuracy and they have to work there. This is huge. Accidents, remember, Exxon Valdez, 3 Mile Island, Bhopal, they all happened during the night when people were sleepy. So there is a huge social, economic, and human life to pay, human cost to pay. You need to develop systems that can screen large number of patients, easily reach them, and then once you reach them, provide customized treatment and monitor it in a larger scale. And basically, you need to do the business differently. Like everything else, we overcome the problems we face, so long as we put our effort and the God-given mind into that. So I think a lot of improvement has been made, although we're still really in the first steps of that. But I think with the attention that's paid now, and especially at a global level, knowing the cost, knowing the damage, and so on, the effort is going to be on it to find better ways of treating them, not only technically for one patient, but on a population base. And I think at the end, these efforts will be successful. Remember, it was 40 years ago, 4 decades ago, that we started to look at cholesterol and smoking coming from Framingham study. And once we knew the impact, now we have less heart attacks than we had 30 years ago. So the same thing will happen there too, I'm sure. First of all, you have to connect them and you have to keep yourself abreast of that. Being or working with residents and fellows and physicians who are being trained in pulmonary disease as a specialist is a big help. Because at the same time that you teach them, you learn. And you give them assignment and you give it back. But I'm personally more interested in the sleep disorder. That's what I do most. But you need to kind of look at all of them and keep them in balance.